Yeah, thank you, Dr. Rubin. That was a wonderful talk, very informative, and it's a difficult topic to cover the length and breadth of risk of surgery in cirrhosis. And with that, I keep it open for discussion. And I see, Dr. Skilsky, it's an honor for you to have in our forum as well. Michael, please, you have the honor to have the first question.
Thank you, Sanjaya. Adrian, always wonderful to see you, and even better to hear you give one of your lectures again. Masterful talk. And I just have a couple of quick questions for you in keeping with some of the data you presented. When you come across the TIPS data and also, the reduction in the HVPG and whether we really, do have a better outcome surgically. One of the other questions I have is, can we reproduce that to some degree pharmacologically using some of our current therapies to lower portal hypertension and use those perioperatively? I know in the setting of living donor surgery, where it's a different story and we want to reduce sort of the blood flow to the graft in the acute phase till the graft has grown in size, that, has been shown to potentially be helpful. But in standard surgical operations, I don't know, how much data there is to kind of support that. And I wonder what your thoughts are.
Actually, there is one study, I think one at least study available that was published within the last couple of years with a massive information I had to present. I apologize for leaving it out, but there was a suggestion that the use of carvedilol, which is the preferred non-selective beta blocker, did give you actually favorable results. On the other hand, the use of beta blockers in surgery and anesthesia is frowned upon because of its inhibitory effect on reaction to blood loss and all the rest of it. So I think it's still it's not yet a formal recommendation. If I can find it later, I can send you this article that was published within the last couple of years suggesting the benefit of a cardiovascular medication approach rather than a mechanical HVP approach. So I think it's borderline. I think it needs more study, but it's certainly a possibility as long as it doesn't interfere with the response to blood loss and anesthesia.
Thanks. I do have one second question, then I'll sort of yield the floor to others here. The other question I have is, when you look at the MELD score, and there's obviously different components to it, and we've all seen the severe, sort of the acute on chronic when they settle back down. And if you look at some of the patients where the liver function improves and the renal function lags, and that's driving the higher MELD, do you think there's a difference in the risk of outcome in those individuals? And the MELD score may, sort of overstate some of the risk for those patients relative to, where the liver function recovers better than the renal function.
Yes, I think I'm glad you raised that. It's a very important aspect to using scores as a global answer to a question. So, for example, you can artificially make the MELD score better by giving plasma and bring the INR down. But that is counterintuitive because we know that transfusion, blood and plasma and so on, during surgery gives worse outcomes. And yet the MELD score can be artificially made better. At the same time, we do know that after acute liver failure and other, especially drug-induced conditions, that the recovery of renal function lags behind the recovery of liver function, and yet the MELD score is going to lag in being elevated. You have to factor in the risk of doing surgery on somebody with impaired renal function. So it's not as if the artificial elevation of the MELD score should be ignored, because in a sense that patient has less resistance to surgery because they've got renal impairment. So it's a mixture. And I think it's why this decision process is an art based on a science, but not purely a science. So I think you have to look at the individual case and say, how bad is this patient's renal function? Can I support them with renal replacement during the surgery, which would make their outcome better? Or on the other hand, will that just be an artificial improvement and the patient on dialysis doesn't do as well with surgery as the patient not on dialysis? So do you wait for the renal function to recover? But if you're waiting, then the reason for the surgery may become more pressing. So this is where you have to balance these factors in an artistic way, in a sense, more than in a scientific way. So the answer to your question is maybe.
Thank you.
Just to piggyback on those questions, I would like to share, we had a publication recently in the ASL, it was presented in the ASLD meeting, and we looked into the MELD components as a MELD as a whole, MELD score as a whole, as MELD components as well. And the patients, and we looked for mortality at 90 days in patients who underwent TIPS at our institutions, about 160 patients around. And those patients' MELD score are driven primarily by the renal function. Actually, they did better as compared to those MELD score driven by bilirubin or INR. So those are the worst outcomes compared to those who actually were just driven by the kidney function. So I think it's important to take a look into those aspects as well, like the individual components, not just the MELD score. In my opinion, based on the study that we had, we just wrote the manuscript. We will be submitting it in a short while.
Yes, in fact, there's a concept of a creatinine. I don't know what it's called now, but a creatinine minus MELD, as it were. MELD without creatinine has a different predictive value than a MELD with creatinine.
Oh, that's interesting. I didn't know that one.
Yes, I can't remember what it's called. It's a two-factor MELD, something. I'm forgetting it now. But there was a suggestion that the creatinine should be considered separately, which is what Mike and I just discussed.
That is used in cardiovascular surgery in patients with cardiac cirrhosis kind of situation.
Thank you, Ben.
Oh,
thank you.
That's good. That's very nice. Thank you.
Well, I see Dr. Murat. Dr. Murat, please, you can switch on your video so we can see you, and please introduce yourself as well, and then, the floor is yours.
Thank you. Thank you very much for your excellent presentation. I would like to ask your daily practice. Do you check hepatic venous pressure gradient in every patient before the operation? Because in some patients, despite low MAT score, especially in cholestatic liver disease as PSG or primary biliary cirrhosis, without high MAT, you can find portal hypertension in those patients. So my question is, do you regularly check in those group or in every cirrhotic patients before the operation, or you only manage these patients with MAT score or child boost score? Because especially in hepatic surgery, the gradient is more predictive tool for decompensation. And
Absolutely.
secondly, do you use indocyanine green test, and what's your comment about it?
Number one, as far as the HVPG is concerned, obviously, if you have clinical suggestion of portal hypertension, low platelets, big spleen, varices, ascites, then you really don't need to check the HVPG because you already know that it's elevated. On the other hand, if you have any suspicion, and I think the situations you mentioned of cholestatic disease where the pressure may be elevated, but the MELD score may not be that great, then I would have no hesitation in undertaking HVPG. It all depends on the availability of the radiologist to do the measurement. If you are confident that you have a radiologist, interventional, who is good at measuring HVPG, but they don't always listen to the hepatologist, but is good at doing that, then I absolutely would. And when we were at MUSC, before I retired, I was certainly doing HVPG measurements in the situations in which you mentioned. HVPG is very safe to do. It's very reliable if they do it the way that Grossman and colleagues described. And therefore, I don't think it's a negative or dangerous thing to do. Much more dangerous for a person to go into a patient going to surgery with elevated portal pressure that you were unsuspecting. And the second question, indocyanine green, no. We never measured that. But there are surgical units in whom they really favor that, and it's very popular in the Far East. Now, there was a while when I was involved in this isotopic non-radioactive C13 methacetyl breath test, where we found that actually very useful. And Todd Stravis and I actually published a paper a number of years ago showing that it was a better predictor of survival than the MELD score. But that's no longer available, and we never used indocyanine green. But there are many places that use it, especially surgical units, and they're very very persuaded by its use. It's experience in interpreting that's important.
Thank you very much.
Dr. Murad, thank you so much for asking that question. Please introduce yourself so the audience know where you're from and about you as well.
I'm from Turkey. I'm working at Koç University in Istanbul. And after a couple of months, I'm going to move to South Carolina, to Greenville, and work for a transplant unit. Thank you very much.
Thank you.
There's a new transplant unit in Greenville. Oh my goodness, yes.
Yeah.
I'm glad I retired.
Thank you for joining and asking that question as well. And we have, our audience actually has people from all over the world here. And is Dr. Raj Uchila here? Dr. Uchila from Australia. Dr. Uchila, a long time I haven't seen you. You're upside down for some reason.
Oh, sorry
That's
about that.
Australia. That's expected.
Oh yeah, yes. Look, thank you. You did mention Tokyo. I live in Perth, Western Australia, so it's a bit. The time's not too bad. It's about 9 or 10 o'clock at night. Look, great talk. Look, I've got a particular question, just in terms of cardiovascular disease and cirrhosis. You did mention in your final flow chart that low MELD, Child-Pugh A, reasonably safe to proceed. But what's the importance of portal hypertension in these candidates? To see more and more of these people with steatotic liver disease who not disease is sort of early MELD, not too close to the transplant anywhere yet, but they do have low platelets and varices. So what is really the right thing to proceed with these people? Because generally the surgeons are very keen to go ahead with the valve replacement, and doing things like TAVI. Maybe they feel is a disservice because they're too young to go ahead with the TAVI, but on the other hand, they have portal hypertension. So it's just your practical thought of proceeding, because in the other chart you did show that Child-Pugh A has a mortality of almost 25 or 28% in the other slide that you mentioned. So just your thoughts on that, sir.
Yes. First of all, please include Turcotte in your chart.
My bad.
All right. Terrible.
My bad.
Because actually Turcotte did all the statistical analysis and was the first time that I think survival analysis was used. Logistic analysis. Turcotte did that. Anyway, how can I put it? Better results in studies with Charles Turcotte CTPA versus B and C, 20, 30, 80%, mortality, still had a 20% mortality for the best cases, even though there were a range of series in those days where it ranged anywhere from 10% to 20%. More recently, the results in CTPA have been worse, with a 28% mortality. And I think the reason for that is that surgeons are becoming more adventurous with the extent of the surgery. Now, I don't have any experience of having TAVI performed in patients with elevated HVPG. But what I would say is, in places where HVPG can be measured well and reliably and reproducibly, it seems to me to be such a simple investigation that if you find that these low MELD, and I mean, if they have varices and ascites, you don't need to do the measurement. But if you have low MELD and you suspect portal hypertension, then you should measure it, in which case you may modify what your approach will be, and that to do cardiac surgery in a patient with portal hypertension is dangerous because you're really giving them the equivalent of a CTPA B or C if their pressures are very high. As for its effect in TAVI, then I probably wouldn't be worried because TAVI is not that invasive. So the answer to your question is, if I suspected portal hypertension in a low MELD, I would get the measurement done. The worst can happen is you find out that it's not got portal hypertension, you can safely proceed because the risk of H3PG in experienced hands is minimal. So the answer to that, I say, would be yes, I would do it.
Okay, thank you.
Does that make sense?
Raj.
Yeah, it does. It does.
Thank you, Raj. Thank you again. And may I invite Dr. Sudhanshu Kesi from Nepal? If Dr. Kesi, if you're still here, I think I just, yeah, Dr. Kesi, yeah. Thank you very much for joining. Dr. Kesi is a prominent hepatologist from Nepal and has actually been using our forum as to educate their fellows and residents as well. This, talks that we already put in the website. Dr. Casey, please.
Yeah, great talk as usual. Enjoyed thoroughly. We do have many cases of surgery that we have to refer to the surgeons, but they usually don't do surgery to in early stage, and in late stage they as the MELD goes worse, then there's no point in doing. So how can we convince our surgeon colleagues to do surgery, especially like umbilical hernia and then inguinal hernia surgery, so that the complications rate are less afterwards?
Persuading surgeons to do something they don't want to do is a psychological skill that is hard to acquire. You have to have years of collaboration where they come to trust your opinion, and that is not something you achieve overnight. I had the opposite sort of problem, and that is our interventionists were extremely convinced that the INR or the PT was a predictor of bleeding in patients with cirrhosis. And I could give lectures to the radiology department. I could show them all the data, and it was just terrible. And I could not convince the older ones. At one point, we got an interventionist who was also a surgeon and had the experience and realized and knew from his training that the PT-INR was not a predictor of bleeding. And so he would do the intervention or he would do the surgery despite the PT and the INR. It's really a question of your relationship. If you can have trust and years of experience of working together, then they will listen to you. But if they don't, then it's very hard to get around that barrier. But for me, to see someone with an umbilical hernia when they're even asymptomatic, if they have cirrhosis, is to get it repaired early before there's any complications, so you don't wait for an emergency. But how you convince people is only by showing them the data, but it's by years of good collaborative of work ethic. That's the only thing I can say.
Thank you very much. Actually, it was more than a simple question than the science that we are having that. And it's very true that it's very difficult to make them understand the fact you have mentioned about the PT-INR. We try to convince them, but they are not still. But I'll have your the slide prepared for them, and then we'll discuss with them. Thank you very much for the nice
Let me
presentation.
just say to that is, I devised a lecture which I would give to the radiology department, showing you all the data, well-established data about the lack of risk of the PT-INR. And it was the younger people, the younger interventionists understood and would listen, and their minds were not set. But the chap who was actually the head of radiology said, I still know what I learned at medical school and I believe it. And I said, but it was wrong, but you have to avoid use of the words like wrong and incorrect and all the rest of it, because this gives them an emotional reaction against the science that you're trying to show them.
Thank you.
Thank you, Dr. Casey. Let me invite Dr. Mukul Rustogi. Dr. Rustogi already put the question in the chat, but if you want to ask the question yourself, Dr. Rustogi, thank you so much.
Sorry, actually, I am in the car.
Okay.
And first of all, I am congratulations to Professor Reuben for such a nice lecture. And my query is that we are encountered CKD patients, which is posted for renal transplant, but they are having chronic viral infections like hepatitis B or C, and they are having early child A cirrhosis. And on endoscopies, there are no varices. So how to approach such patient so that we can give the clearance for renal transplant only, not for combined liver and kidney transplant?
I think that it all depends on the individual. By the way, I hope you're parked and not driving. But it depends on the severity of the liver disease and so on. But if we can follow the guidelines that I mentioned, then I would proceed to renal transplantation. One of the problems is in that situation, if there's some degree of hypersplenism, is immunosuppression may be a little difficult. But otherwise, if the patient has cirrhosis and doesn't need a liver transplant, then I would proceed to renal transplantation. The alternative is I think less favorable, is to wait until the liver catches up and they need a combined liver kidney. But as long as the liver disease is stable and non-progressive, and with hepatitis B and C, we have such excellent antiviral treatments now that you can really promise that the liver disease will not progress, then that's an even better reason. They're on antiviral medication for doing kidney transplant, as long as they don't have portal hypertension.
Yeah, I think the routinely in our just to add on to it, Mukul, I think routinely in our center, so we actually measure HBPC in these patients, and if it is more than 12, we tend to recommend that you have a combined liver and kidney transplantation. But if it is less than 12, like say not significant portal hypertension, then only isolated kidney transplantation.
Yeah, I agree. Yeah.
If they have varices or ascites, then there's no question.
There's no question. Correct.
And if you're not sure, then I would definitely, in anybody undergoing operation as big and important as renal transplant, I would always get HVPG measured.
Thank you, Professor, for the nice answer. Thank you so much.
You had a second question, right, Mukul? You had a second question, I thought.
Yeah. So I just want to ask you that everybody is not expert in assessing HBPG, and there are no varices on endoscopy. So how will we prognosticate the patient that there is very less chances of decompensation after the renal transplant surgery?
Well, it's not just varices. You should get abdominal imaging, obviously, see ascites. That's difficult in a patient with kidney disease. They may have fluid accumulation for different reason. So you have to measure the proteins in the ascites and try and decide, is it portal hypertensive or is it not? The platelet count is going to be important as well. So there are collateral factors you can measure that will give you the clue that there may be portal hypertension. But you should make every effort to get the interventional radiologist trained in HVPG measurement. I mean, it's a stock in trade for radiologists these days. But use the collateral information, though, the platelets and look for ascites. If ascites is present, sample it, measure the protein so you can distinguish whether it's cirrhotic or not, or portal hypertensive ascites or not. You can make these extra measurements that help you. And also now with elastography, elastography can give you quite a good indication of basically of portal hypertension as well. There are good studies on that now.
But I have a doubt in elastography, because in CKD patients, the value of elastography is falsely high. So you cannot assess exactly what amount of fibrosis is inside.
No, I understand that, but you know, there's no simple answer. You have to do as much as you can and put the data together and then use your experience to say, I choose not to take account of the elastography for the reasons that I know. But you have to do something, and you have to put all the data together and then look at it and use your clinical experience. That's why I say there's a certain amount of art versus science in all of this. And when I say art, what I mean is experience and common sense.
Thank you. Thank you, Mukul. Thank you so much for joining today and also asking that question, while you were driving in your car.
I hope he's parked.
I think I have a question from Dr. Maxon, Emma Maxon. Please, Dr. Maxon, if you want to ask that question yourself, and please also introduce yourself, Dr. Maxon. Yes, please. Yes.
Thank you so much for such a fabulous talk. Can you hear me okay?
Yes, we're hearing very well.
I'm a clinical fellow at King's College Hospital, and we're actually in the progress of setting up a perioperative pathways assessment as part of our advanced chronic liver disease service. And we're really looking to see some of our patients are undergoing TIPS, and we're trying to gather the data prospectively to assess their outcomes. I was just wondering what do you think of TIPS to optimize pre-surgical risk? We've seen in the last year, we've had an increase of referrals, especially with colorectal cancer. And I think in opposition to what some of the other colleagues were saying, actually our surgeons are very keen to operate. So sometimes we feel like we almost have to to advise that, we're very worried about this.
Look, the results of prospective studies on TIPS are few. There are many retrospective studies, and there are many meta-analyses and so forth. But there's not a uniform conclusion from all of them. I showed I forget now how many, was 4 or 5, where the answer was yes, no, and maybe. And in the latest editorial that I quoted, Operating Under Pressure, came to the conclusion, based on really only one study that this editorial reviewed, that it was the right thing to do in most circumstances, and it should be done early rather than later. But we need prospective studies on that. In other words, people do the TIPS, the pressure goes down, but there aren't that many reports of the prospective studies, and it's of different forms of surgery. It's not just one form of surgery. It may be good for abdominal surgery, but not so good for cardiovascular surgery. So I think we need more prospective studies on the results of TIPS in different types of operation. And I think if you're developing a pathway, that's going to be marvelous.
Thank you very much.
This is great. In fact, in many centers, I believe at least those patients who have ascites, and you are trying to do an umbilical hernia repair, I would say. I mean, most of our surgeons like to have control of the ascites. And we do TIPS in many of these patients. And once ascites is controlled, we do the hernia repair. In many cases, we're quite successful. But again, the studies we need to quote, and we need a better.
There is this risk that I mentioned. There's this strange risk of, if the ascites is improved, whether with TIPS or with drainage too quickly,
they do develop
can incarcerate. And
yes,
actually,
that's true. That is also.
So, and with tips, you can't control the rate at which the ascites, sometimes you put a tip, so the ascites improves extremely rapidly. And that can actually be dangerous. You have to be very, very careful about that.
And yeah, and that happens in many a time as well. I mean, this is a caution that I think we also have to take in mind. Let me ask Dr. Prasoon Jalal from Texas. Dr. Jalal, please.
Thank you. This is an outstanding lecture. Thank you, Professor Reuben. Yeah, I think this is more comment than a question. This HPPG story is coming back and all the time in the discussion as well. And I think the tips are still in evolution. We need to have more data because, as you all mentioned, our surgeons, most of the time, with ascites, before they do any abdominal surgery, they want us to do tips. Also, another reason they want us to do tips is because they feel like all these collaterals, variceal bleed, in erythroperitoneal or wherever it can open up, the reduced chance of bleeding after tips. So they sometimes use it for decompression of those varices. The other comment is about increasing mortality. I believe it could be partly due to ACLF and alcohol coming on board more than in viral diseases as a cause of liver disease in the past. Because as you mentioned, that alcohol, especially alcohol in hepatitis, associated hepatitis, has got higher mortality. There is no doubt about it. My question is, do you feel that, because inflammation is an ACLF, is getting predominantly more and more in our liver disease world, do you think we need to revise this CPT score, putting Pew in the middle, or MEL score? We should be focusing other types of scores, whether it's ACLF scoring system. We need to come up something different based on the setting. And also, do you believe that there'll be any role of antibiotics, prophylactic antibiotics, to reduce the infection or inflammation or outcome?
I'm not sure I totally understand the question. What you're saying is, if you are working with ACLF or an operation that will precipitate ACLF, what form of prophylactic treatment could you use? Remember, not all ACLF as a result of surgery is due to infection. So, any inflammation can precipitate ACLF. And then, so doing prophylactic antibiotics may not work. I think the only way to know would be a controlled trial, because it could go either way. And with respect to having another predictive score, right now there are many. I mean, to me, the most useful score with its limitations is the vocal pen, because it takes account of the type of surgery, it takes account of the emergency or non-emergency side of it, it takes account of ASA and age and so on. The only problem with that, and it's been well validated in external studies now, is the fact that it was originally devised on a very specific population of men of lower socioeconomic status. So I would be inclined to use the vocal pen in every case as much as I could. I think you calculate the other scores, but if they don't make sense or they're not giving you an answer that you think is logical, then you have to look to see why it is. One of the things, of course, is like the creatinine in the MELD and so on. So I think unless someone's got the effort to produce yet another score, and then it has to be validated and so on, I would be inclined to use the scores that we have and look at them more, give them more scrutiny.
Thank you. I agree.
I mean, your question is a very important one, but I don't think we have an answer. That's the problem.
Right. Thank you.
Thank you, Prasoon. And may I invite Dr. Benedict Maliakal, please, from Nashville, Tennessee.
Hi, thank you for that excellent talk. Especially the history of this thing is important and giving the right people, credit for what they have done in the past. I I have this kind of a proposal, which is, both HVPG and liver function are important for outcomes. And therefore, we have to address both depending on the MELD score, depending on maybe indocyanine green and HVPG. And one thing to improve portal hypertension uh, without decreasing liver blood flow and also worsening cardiorenal issues may be proximal splenic artery embolization instead of TIPS to lower HVPG from, say, 15 or 16 to below 10. And that might be a better way of decreasing portal hypertension in this kind of a situation. And the second thing is that inflammation post surgery and infection, I think, causes liver and multi-organ failure, mostly related to microparticles that are generated during damage. And therefore, in high-risk patients, we should think about plasmapheresis post-surgery for just like an ACLF protocol, but albumin. Be
Question of doing splenic embolization. This has been raised before, and the problem is that the acute benefit of splenic exclusion is short-lived. And this was, I forget who it was now, there was a surgeon or radiologist who was recommending that to reduce portal hypertension. And the problem is if you measure portal pressure, it goes down. In fact, if you put a balloon in the splenic artery and you inflate it and you produce immediate splenic exclusion, portal pressure will go down. But if you look chronically at the effect of splenic embolization, I'd have to find the articles, and now right off the top of my head, I can't remember which ones were, but the portal hypertension actually recovers. So the splenic embolization, I do not believe is an answer. Now, as far as all the other strategies that you've mentioned, they all seem sensible and based on what we understand of the pathophysiology. But until they're done on a large scale, and especially with a prospective trial, then I don't think we know whether they're, I mean, plasmapheresis and removing microparticles is a wonderful idea, but unless somebody, and again, look how long it took the Danish group to get accepted the idea of albumin infusion. There were years and years of study before they finally got enough cases together to produce a publication. It took ages. And so, without prospective data, best done in a controlled trial, I don't know the answer to your question. There are some procedures. I give you one funny example. I had a lot of back discomfort, and I had actually facet joint inflammation, and the neurosurgeon recommended steroid injection, and the insurance would not pay because there were no controlled trials showing that this treatment worked. In fact, I was one case, I had it done and it worked wonderfully, but this is not admissible evidence, you see. So I think your suggestions are creative and imaginative, but unless someone is doing a study that gives you statistical, reliable benefit, it's not going to be accepted. That's a problem.
I agree. I mean, it is just a proposal because based on what we know today, I think it is a worthwhile study to consider.
Yes, it should be a multi-center study. You know, the alternative is you do it yourself and you use historical controls, and then the answer will be, when you try to get it published, is this has to be a randomized prospective study. So, you know,
I agree.
there has to be a way of getting the work done.
Thank you, Dr. Miliakal, and thank you for that excellent suggestions. And I hope that our audience will take it into account and maybe will come out with some sort of a randomized study in the future. And these are ideas that you bring up when you discuss
Yes,
in
you
this
should
kind of
write up
forum.
a study and
Yeah.
try and get some funding and recruit candidates, PIs from all over the place, because there are enough people interested.
Yeah.
I recently did a proximal splenic artery embolization on a patient who was post-transplant with semi-refractory ascites who had recurrent umbilical hernia incarceration. It's an N of 1, I guess. He did very well after the surgery. I did a splenic artery embolization, and his ascites got much more medically controlled, but it's just an N of 1.
How long is the post-treatment follow-up?
More than 6 months.
Yeah. Look, it's not to say that it will not work in individual cases, but overall, there are data, I should say, that show that the portal pressure recovers after you occlude the splenic artery. And I'd have to find that data now, but I remember Roberto Grossman preaching that a lot, that because there was this radiologist in New York, or surgeon, I forget, who was publishing stuff showing that splenic occlusion actually improved portal hypertension, and the result of all the investigations were that the portal pressure recovers. That's not to say it's going to do it in every case. Also, I don't know whether there was any degree of fistula, because one place in which splenic embolization will work is if there is a splenic artery fistula. There's arteriovenous fistula, because that produces portal hypertension that is amenable to reducing the arterial inflow, but that's a rare cause of portal hypertension.
Yeah, I mean, I think the splenic artery embolization will, at least for a few weeks, give you some benefit. And that, what I've found in the patients I've done this is that their ALT actually decreases and their creatinine somewhat improves and their shortness of breath gets better, because I think the cardiac output, which is really high, decreases, and it helps the cardiorenal system too.
Sure, if a short-term benefit, I would agree, could happen, but as a long-term solution, I would say no.
I agree. I mean, but in a situation where somebody has, say, colon cancer and needs surgery, this might be, instead of doing TIPS, which I think is a problem because it increases cardiac output further, and that may not be good for the heart.
Thank you, Ben. Thank you for sharing your thoughts. Let me move on to the last question, although we are beyond our stipulated time. Dr. Reuben, do you have permission to have one more question?
Yes, I can have my lunch in 10 minutes' time.
All right, Dr. Monges Pragdala. Dr. Pragdala, please.
So thank you, Dr. Reuben. This is a very important topic. I'm a transplant hepatologist in Dallas. I feel very confident taking care of liver patients, but when it comes to prognosticating patients for surgery, it makes me a little nervous, especially looking at these scores, because I personally believe, so this is a very philosophical question. The risk of not proceeding with surgery depends not just on the liver disease severity, but also on the underlying pathology like cancer, infection, or trauma. And when you look at most of these scores, they were all like prospective. And I just feel that they kind of left patients out that were deemed too high risk for surgery. So that means we don't have any data on non-operative management in these populations. So I just wanted to see what your thoughts are on these kind of in this situation.
Look, let's take an absolute example of an emergency. If there's an emergency, you have to do the surgical treatment. You have no choice. The results we know of what the people call emergent, I don't like that word, urgent versus elective are worse. We know that. But on the other hand, not doing anything in a situation that could be fatal is wrong. So the patient's chance of survival without the surgery could be terrible. And the patient's chance of survival with the surgery is not as good as a non-cirrhotic, but is better than dying. So, I think you have to use a combination of these scores and common sense and experience and say, does the result of such a score make sense? If it doesn't make sense, then you have to look and say, why doesn't it make sense? And does my experience tell me that to proceed with surgery would still be a reasonable idea, bearing in mind that the comorbidities or the complication rate and so on might be worse. So I understand what you say, but I think you're better off to make the measurements and discard them than not to make the measurements at all.
So talking about those patients, for example, somebody needs a Whipple for a pancreatic lesion, and if their mortality score at 90 days is, let's say, like about 20% or 25%, and trying to subject them to medical management versus a Whipple, which could be increase their outcome. I'm talking about those
Whipple for pancreatic cancer.
Let's say somebody with cirrhosis.
No, but what's the Whipple being performed for?
For pancreatic cancer, stage 1.
Yeah, I only wish that the results of treatment for pancreatic cancer were better. So yeah, doing the Whipple might be a good idea, but the recurrence rates are enormous. That's not to say you shouldn't do it, but you have to be a little bit more sanguine about what the surgery will accomplish in the long term. And that's a decision that one thing I missed out in one of the slides, I cut out part of a slide, is the informed consent and the patient involvement and all the rest of it. These are parts. Now, sometimes the patients say, well, look, if I have no chance of living, I'll take a 10% chance of surviving. And if that's a transplant program, transplant won't be done unless the transplant program can show greater than 85, 90% chance of survival, then they won't get licensed. So these are different considerations other than just the straightforward numbers on survival. So doing a Whipple, I'm very worried about that because the long-term results of Whipple are not good. But if the patient prefers to take the chance and the surgeon will take the chance of operating and have poor outcomes, then that's something that may be the consensus between all of you, the family, the patient, the surgeon, and yourself might be to go ahead.
Thank you.
Thank you, Mangesh.
These are difficult questions, difficult problems. I wish I had, I don't want to be glib, but I wish I had a better answer.
Well, I mean, we come to the end of the meeting today. This was wonderful and then very good discussions, very engaging discussions. And I really want to thank everybody who joined today. And thank you, Dr. Reuben, as well, and for finding some time for us from UK and also our audience from all around the world. And hopefully we'll see you back, all of you again in 2 weeks' time for another wonderful lecture. And thank you everyone for joining in this weekend on a Saturday morning here in the US.
Very delightful. Thank you.